Welcome back again to Strong Independent Pharmacist Podcast. Talking about new health issue here is Maram and Adam.
Right. And just to jump in, I love that we're starting exactly with that quote from our source material today. It perfectly sets the medical theme.
Yeah, exactly. I wanted to read that right off the clinical notes they gave us to sort of anchor this whole discussion because today's mission is pretty massive.
It really is. We are diving deep into the initial pharmacologic management of adult type 2 diabetes, which, sounds like a mouthful.
It does, and that's why we're going to cut through all that dense medical jargon. We want to discover how doctors actually decide, which medication to prescribe first.
Because it's definitely not a one-size-fits-all approach. It's a highly customized blueprint.
Right, and whether you're studying for a medical board or maybe managing your own health or honestly just insanely curious about how modern medicine works, this deep dive is going to give you those aha moments.
Absolutely. You'll actually understand the logic behind the prescription pad.
Okay, let's unpack this. Think about managing newly diagnosed type 2 diabetes, like putting out a house fire. Do you start with a bucket of water, or do you need to call the fire department right away?
That is a great way to frame it. Because before a doctor even reaches for a prescription pad, they have to look at the baseline metric, which is the A1C level.
Right, the A1C. That's basically the overarching diagnosis number.
Yeah, and they also have to look closely at the patient's lifestyle. That is the very first decision point.
Okay, so obviously early treatment prevents long-term complications, but what if the A1C isn't super high?
Well, if the A1C is near target, so under 7.5%, and the patient is highly motivated, a 3 to 6 month trial of lifestyle modification is actually totally reasonable.
Wait, really? Just lifestyle?
Yeah, before trying any drugs at all. And even if the A1C is a bit higher, if there's a clear modifiable culprit, like, say, heavy reliance on sugar-sweetened beverages, a 3-month lifestyle trial might still happen.
Okay, wait, I have to push back on that. Because the source specifically says weight loss underpins all effective type 2 diabetes therapy.
Right, it does.
So why don't we just mandate a 6-month diet for everyone? Why rush to medications if their A1C is over 7.5%? If the house is actively burning, you don't just stop buying matches, right? You need an extinguisher right now.
What's fascinating here is how the clinical guidelines explicitly factor in human behavior.
How so?
Well, it isn't just about the numbers. It's really about the patient's motivation to change. Treating a human is fundamentally different than treating a spreadsheet.
Oh, that makes sense. You can't just assume everyone is going to completely overhaul their diet overnight.
Exactly. But when those lifestyle changes aren't enough, or if the A1C is so high that it requires immediate action, the vast majority of patients are pointed toward one specific starting line.
Metformin.
Yes. Metformin is the undisputed champion here. It's the preferred initial therapy for asymptomatic patients.
And the dosing on that is pretty specific, right? The sources mentioned starting at 500 milligrams once daily.
Yeah, usually with the evening meal.
Oh.
And then they titrate it, which means slowly increasing the dose up to 2,000 milligrams a day.
But here's where it gets really interesting to me. We hear about all these flashy, new, incredibly expensive diabetes drugs on TV all the time.
Oh, constantly.
So why is this older, dirt-cheap pill still the gold standard?
It comes down to its unmatched track record. Metformin has high glycemic efficacy, meaning it works really well at lowering blood sugar.
Right.
Plus, it promotes modest weight loss. It has a very low risk of hypoglycaemia, which is dangerously low blood sugar, and it has no adverse cardiovascular effects.
Wow, and it's super cheap.
Very low cost. It essentially avoids the weight gain associated with older drugs like sulfonylureas.
Yeah.
And it avoids the heart failure risks of things like thiazolidinediones. It's just a reliable anchor.
But it does have some side effects, right? I know people complain about stomach issues.
Yeah, gastrointestinal intolerance is the main one. But to manage that, you just tell the patient to take it with food, titrate the dose up slower, or use an extended release formula.
Gotcha. Okay, so metformin is the anchor. But what happens when the patient has a really complex medical background? Because I imagine the standard blueprint kind of gets thrown out at that point.
It absolutely does. This is where the treatment path splinters out dramatically, moving way away from metformin monotherapy.
Let's talk about those specific splintering paths. What if the patient has heart disease? The sources call it ASCVD.
Right, atherosclerotic cardiovascular disease. If a patient has that, the guidelines prefer GLP-1 therapies. Those are drugs like dulaglutide, semaglutide, or tirzepatide.
Which are super popular right now.
Very much so. Or, alternatively, doctors might use SGLT2 inhibitors like empagliflozin.
Okay, so that's for heart disease. What about heart failure or diabetic kidney disease, the DKD path?
For heart failure or kidney disease, SGLT2 inhibitors are the absolute go-to.
Now, hold on, let me get this straight, because I read the source material carefully.
Okay, go for it.
If someone has kidney disease, we give them an SGLT2 inhibitor. But that's a diabetes drug that the source specifically says has less glycemic efficacy in patients with poor kidney function.
That's right.
Meaning, if their eGFR is under 45, the drug doesn't even lower blood sugar that well anymore. That sounds totally counterintuitive. Why prescribe it?
If we connect this to the bigger picture, it actually represents a massive paradigm shift in modern medicine.
How do you mean?
Well, the goal shifts from merely lowering a number on a glucose meter to actively protecting the failing organ.
Oh, wow.
Yeah, so even though it's not lowering the sugar as much, it's shielding the kidney from further damage. We're treating the complication alongside the disease itself.
That is mind-blowing. The primary job of the drug literally changes based on the patient's condition.
Exactly. Now, moving on to another major comorbidity, obesity. If that's the primary issue, GLP-1 therapies are preferred.
And the source notes that tirzepatide provides the greatest weight loss, right?
It does. But we also have to talk about the extreme cases. What if a patient comes in and their numbers are just off the charts?
Right. The source calls this severe catabolic hyperglycemia.
Yes. So if their A1C is over 10%, or their fasting glucose is over 250, or if they have ketonuria and unintentional weight loss.
Meaning their body is basically breaking itself down and spilling ketones into the urine.
Precisely. If that's happening, you skip the pills entirely. Metformin is way too slow here. Insulin is required immediately.
Because it's an absolute crisis, you need the master key right then and there.
Right. You have to stabilize them immediately.
Okay, so we've discussed these amazing biological ideals, the GLP-1s, the SGLT2s, the insulin, but we really have to ground this in reality for a second.
Ah, yes. The real-world constraints.
Yeah, because how do patients' wallets actually impact these clinical guidelines?
It's a huge factor. GLP-1s and SGLT2s are incredibly expensive.
Like, shockingly expensive.
Exactly. So formulary coverage, what the insurance company will actually pay for, often completely dictates what a patient can take.
So what happens if cost is the primary concern? What do doctors do?
If cost is the issue, they often have to fall back on older drugs like sulfonylureas, drugs like glipizide or glypyride.
And the World Health Organization actually supports using those, right? Because they are cheap and they do work.
They do support it, yes. But there's a serious trade-off. Sulfonylureas cause weight gain, and they risk dangerous hypoglycemia.
Yikes. Are there any other cheap options?
Well, there's pioglitazone. It's cheap, and it's actually quite good for patients who also have fatty liver disease, or MASH. But it brings its own risks, like fluid retention and even heart failure.
So what does this all mean? Are we basically just trading optimal health outcomes for whatever the insurance company will pay for?
This raises an important question about our systemic healthcare, honestly. But practically speaking, for a doctor, it completely elevates the importance of patient education.
How so?
Well, if a patient is on a cheap sulfonylurea, the education basically becomes the actual medicine.
Right, I love that phrasing. The education is the medicine.
It has to be. Teaching them to adjust their doses during exercise, or if their diet changes, that is the only way to keep them safe from sudden dangerous drops in blood sugar.
So the prescription isn't just the pill, it's the knowledge of how to use it without hurting yourself.
Exactly. You mitigate the risk of the cheaper drug through intense education.
Man, that really puts it into perspective. Let's just briefly recap this journey we've been on.
Sure, it's been a lot of ground to cover.
We started by exploring the criteria for a lifestyle trial, figuring out who actually gets to try diet and exercise before pills.
Right.
Then we looked at the absolute dominance and utility of metformin for the standard patient.
The anchor.
And then we saw how serious comorbidities like heart and kidney disease or even severe financial constraints can completely alter a doctor's prescription strategy.
It's never just a simple flowchart.
No, it's not. And for you listening, this is exactly why this knowledge empowers you. You now know that prescribing is this really complex negotiation between biology, lifestyle, and economics. You are armed with the why behind the prescription.
It changes how you interact with your doctor.
No.
But before we go, there's a final, really fascinating thread from the sources that I think we should leave everyone with.
Oh, yeah, the insulin thing. Go for it.
So historically, insulin is seen as a last resort.
Yeah.
Right. Something you use when everything else fails.
Right. Nobody wants to be on insulin if they can help it.
But the sources note that short-term intensive insulin therapy right at the moment of diagnosis can actually induce near normal glycemia.
Meaning perfectly normal blood sugar.
Yes. And hitting the disease hard with insulin right on day one can actually improve the body's own endogenous insulin secretion.
That is wild. It's like it gives the overworked pancreas a vacation so it can heal.
Exactly. Sometimes it allows the patient to maintain their blood sugar with just diet and exercise for months afterward. No pills at all.
So, could the future of diabetes care be hitting it hard with insulin on day one to literally reset the pancreas?
It's definitely something for you to mull over until our next deep dive.
Truly amazing stuff. Thank you all for joining us on this deep dive, and we'll catch you next time.